Top Med Talk.
Hello, welcome to Top Med Talk. I'm Andy Cumpstey and I'm back here at Evidence-Based Perioperative Medicine's World Congress with my co-host Joff Lacey. It's been a busy day, hasn't it, Joff?
It has, yeah, lots going on.
And you've just been sneaking in and out of some of the various sessions, trying to get a bit of insight whilst we've been podcasting.
Yeah, exactly. I just was in a session where John Whittle and Mark Edwards are going through some of the updates on cardiovascular risk assessment for non-cardiac surgery, and we'll hopefully chat to them a bit later on.
Yeah, exactly. A sneak preview.
Yeah, exactly.
Links pretty well to what we're going to talk about now. So I just caught the very end of a really interesting session about some breaking trial news that has just been published in, I believe, the New England Journal of Medicine a couple of months ago. So it's a great pleasure to introduce Vas. Will you tell us a little bit about yourself, Vas?
Yeah,
who you are and where you come from?
First of all, thanks for having me on this podcast. I'm Vasileios Panoulas, so I'm an interventional cardiologist and I work at Brompton and Harefield Hospitals. My main base hospital is Harefield. One of the very busy interventions there. We do lots and lots of primary PCI and we're heavily involved in people with cardiogenic shock. We have close links with paramedics across 3 areas, so we're very busy. So we do a lot of mechanical circulatory support, and that involves this myocardial pump called Impella, on which we're going to talk about, and also extracorporeal support with ECMO.
Excellent. So really, really busy person. So thank you for sparing the time to come and spend some time with us chatting about this trial now.
Sure.
This trial was the DanGer shock trial.
It's called DanGer shock, yes, because initially it started in Denmark. So Jacob Muller, who basically got the inception of the trial, is Danish, and they started in Denmark. They were recruiting a little bit on the slow end, and then they decided to expand to Germany. Obviously, it was a very busy MCS country. And then finally, they included the UK, because they realized we're also quite a busy center, so we managed to contribute a few patients in that trial. I'm very proud of that.
And what was the trial looking at, Vas?
So in essence, it's a trial looking at people coming in with acute myocardial infarction, ST elevation, so the ones with a kind of high end of infarction, with cardiogenic shock. And it was randomizing basically the patients to standard of care or whether standard of care plus myocardial pump called Impella. And he wanted to see whether having the Impella device would make any difference in your mortality at 6 months down the line.
And sorry to interrupt, but just before we go further, for the benefit of the listeners at home that may not be fully sure what an Impella device is or may not have seen one before, could you just summarize when it might be used, how it works, what it is?
Sure. So it's a device that is made of, it's called myocardial pump. So it's based on the Archimedes screw principle. So it has a little motor and one of those things that resemble the speedboats. And
right.
That's like a propeller that goes very fast and basically has a nitinol frame tube, and you position it across the aortic valve. And basically there is an inlet where the blood is sucked in from the left ventricle and an outlet that the blood is spat out into the aorta. And basically it's a continuous motor pump that continuously across the heart cycle just pumps blood from the LV out in the aorta. So that's essentially how it works. You can implant the small ones, the one that's called CP or Smart Assist, through the groin. So you make a little hole, 14 French. We'd like to do that a lot to us interventional cardiologists. You go with a wire up the heart, cross the aortic valve into the left ventricle, and then you advance the device over a monorail into the heart, and you position it in the right place. There's also a bigger one now called 5.5, and that depends on the volume of blood it can pump per minute, and that you can put surgically through a cut down of your axillary artery. So there's that option.
And prior to the trial, can you just tell us how these devices were used in routine clinical use?
In our institution, we have been using them for quite some time, nearly a decade now, more for people quite deep in shock. According to the SCAI classification, I would say probably Ds and Es. There was a lot of people that were decompensating heart failures that would need a device to get kind of eligibility for heart transplantation or an LVAD. As you know, we're also a quaternary center. But there was no randomized evidence as such to guide us as to which exact population would benefit from this device, particularly when we talk about those coming in with a big infarct, primary PCI. So with primary PCI, we would use it because we have the expertise and we could see that this device actually offers benefit. But there was no randomized evidence up until this point in April when this study was published to kind of justify, let's say, it used also in a more randomized fashion. So now that we have the evidence, it made our life easier because we know which patients to select. basically people that have predominantly left ventricular failure. The study defined it as less than 45%. The patients needed to have a raised arterial blood lactate, so more or equal to 2.5. So you needed to have basically an aerobic metabolism, which is kind of an advanced stage of shock. And then people that would come, of course, with an acute MI. So you need to have ST elevation. But it was quite clever in the sense that it excluded the population of comatose out of hospital cardiac arrest. Because a lot of these people can come and have an arrest in the community and come to us with variable downtimes, and then you don't know about their neurological recovery.
Yes, of course.
So the study was trying to kind of select population that we knew that were neurologically intact. So then if any outcome would happen, probably would be related to their cardiovascular issue rather than them having a downtime and a neurological injury. And this is kind of the biggest probably difference of this trial and the ECLS trial of Holger Tiedles that was presented in the ESC conference last year. That was a negative trial comparing ECMO versus conservative. And probably the reason it was negative is because 77% of the people recruited there were actually out of hospital cardiac arrests. And on that trial, there was no inclusion criteria that involved echo. So there was no criteria involving a poor LV function. It was mainly based on lactate and blood pressure. And of course, if you arrest, you come round, your lactate might be up. And even though your heart might actually have recovered, so then you might not need a device.
Yes.
So this study was mainly focusing on patients that have pump failure, and particularly LV pump failure. It's also important, I think, to highlight that they excluded people with RV failure. They excluded people with the mechanical complications of the MI. So if they had VSD or an LV rupture, obviously you're out. So it was quite a pure, let's say, trial. But if I remember correct, roughly the 1,200 people that were screened, 360 were included in the trial. So a lot of those, I remember nearly 500 were comatose cardiac arrest, so they were excluded. And then you have other things like futility. If someone had metastatic cancer in DNA, obviously you're not going to subject them to a device, and other reasons to be excluded. It's a very robust trial with what I think is a very high number needed to treat. So in medicine, we use this term number needed to treat to see how impactful is the benefit. Because, there's a lot of positive trials out there, and some of them say, number need to treat 100. So you have to treat 100 patients to save one life. In this trial, the number needed to treat is 8. So you only need to treat 8 patients to actually save a life.
Which is pretty astounding, isn't it?
Pretty impressive.
If we look at other trials across the board, there's not many giving single-digit number needed to treat values.
Absolutely. And then even if you look at it from absolute difference, so in 6 months, there was a reduction in mortality of 13%. So that's quite a big number as well in my point of view. So, and if you want to put it into comparison, in 1999, there was a study from Hoffman about whether we do primary PCI in people with shock or not, or with thrombolysis. And that study basically showed that in 180 days, you had 13% survival benefit if you do primary PCI. And that's why, and saying that was their secondary outcome. The primary output was 30 days, and that was negative.
Wow.
And based on that trial, we have made in our guidelines 1A indication, 1B indication of waking up in the middle of the night fast and go and do the primary in that patient that comes in with shock, because revascularization seems to save a life.
Yeah.
And guess what the number needed to treat was? 8.
Wow.
So now we have another trial that on top of the revascularization, we can deploy another therapy and then save another life for every 8 we use a device.
And in the trial, how were you using the Impella in that PCI process?
So there was not a mandate to use it before, during, or after. So you could use it whenever the shock occurred within 12 hours of your PCI. So if you fulfill the criteria before, you could use it before, and a lot of time, nearly 50% of the time, it was put in before. If it happened during your PCI, you could put it during your PCI or even after, as long as it's within the 12-hour window. One thing I think we should highlight is that any device you put in comes with a cost of complications. And of course, the problem with devices that have large bore access, the first complication that comes to mind is bleeding. So in this study, again, as with every other study with mechanical circulatory support, it showed about 20% of bleeding. But of course, we need to highlight that even the conservative arm, there was a 12% risk of bleeding. So these patients, obviously, we treat them with a lot of heparin, anticoagulants, antiplatelets. So, we can also promote it. But it also highlights to me that if we need to be very careful how we put these devices in and be very meticulous with our implantation techniques, because good practices do make a difference. If you avoid the bleeding, you probably have a bigger effect, a better benefit.
And were there any other adverse events or other risks?
We had also, I think the study showed a higher rate of renal filtration therapy. I think it was around 40% in the Impella arm and 20% in the non-Impella arm. But obviously, these also depends on your intensive care unit, what's the thresholds for filtering. So some people filter just to, offload a bit, or if they see a bit of crowding going up. But what is important and interesting for us as clinicians is how many patients end up on dialysis in the long term, because that is basically a change of your life circumstances. And reassuringly, at 6 months, there was no patient in the Impella arm that was on dialysis. So even though 40% were filtered, that didn't translate into a long-term disability. But then the other thing to take into account is when you start talking about these complications, it means that the patients have survived to be filtered. So then comes this thing called selection bias. So if people in the non-Impella arm died early on in the beginning, obviously there's a little bit of a selection of the best patients who probably didn't need filtration.
I think all those points are very good points, because when I was looking through the data, I think that's one of the effects which surprised me, in that I was expecting the patients with the Impellas having, if you like, better forward flow to have less need for renal replacement therapy. So that's a surprising finding, but I guess it shows the power of the data and also all these other important considerations that you highlighted very well.
And I think there will be sub-analysis on the matter, and I don't think the investigators deny the fact that obviously if you have hemolysis, the plasma-free hemoglobin can be a very powerful thing that destroys your kidneys. But we also need to put it in a bit of a perspective, because there's this competing outcome of death, and that's always a problem in long-term trials.
Yes,
we see that in the TAVI trials. There's a lot of talk now about structural valve degeneration, but then 10 years down the line, but then actually how many people have survived for us to be able to look at their echoes at 10 years? Maybe 30%? And what about the others ones? So you have to put all these things into perspective when you look into those.
So do you think that the trial has given you the answers that you need to change practice, or are there some questions left unanswered that you hope to resolve in the short, medium, long term?
So, I think there is no higher form of evidence than a randomized trial. And particularly when it's an investigator-initiated trial, then you also have the reassurance there was an original idea that came from people that, don't have any interest or conflict of interest as such. It was well-powered, it was well-executed by teams that know how to do their job. But for me, what it gave me is the reassurance that the device works, but you also have to have best practices. So it's a bit like every mechanical circulator device. It's not for everyone. It has to be done at high volume centers, and it has to be done well for it to show the benefits. If you start deploying these devices in every little hospital that performs one Impella a year or two, I'm afraid it's probably not going to fly. I think that's the bottom line. There was another trial lined up, the Recover 4 trial, but I think it has been halted because of the result of the DanGer, because obviously the committee's thing now, it's unethical to not provide the therapy. But what there is still work to do, I think, is that group that is pre-shock. I think there is ongoing trials for that. There's what we call the STEMI DTU trial that looks into people in a pre-shock state, I would say, with poor LV function, high LVDPs, and checks whether Impella up front and unloading for half an hour before revascularization. It's a bit mad, but that's the concept. Will reduce the infarct size. And if that study shows something like that, then we're talking about not only preventing death, but you're talking about preventing heart failure and promoting myocardial recovery. So watch the space. I think there's a lot more to come.
And again, the end of the session that I just caught that you were talking about here at the conference, there was a very good question asked about the cost of these devices, which obviously factors into all of these new treatments, whether that's a monoclonal antibody for cancer or a new mechanical device for patients with cardiogenic shock. I mean, what is the cost of these devices, but also what's the associated cost in terms of the training time, the post-operative follow-up time, and so on?
Yeah, I think the cost of the device. The problem is that it varies from country to country, and and I'm not sure I'm allowed to declare the cost on this podcast.
Sure, fine, okay.
I can tell you the ballpark of something like the 15,000 or something like that at the moment. But equally, any cost up front, for example, a device might translate into fewer ITU days, for example, or better LV recovery. And then in the long run, that means if it's a young patient, faster return to work, less hospitalization for heart failure.
Yeah.
So all of these things have to be factored in a kind of multimodal costing of particular treatment. Yes, there is a lot of investment in training. We are proud that we are running a lot of courses about MCS, and we get people to have a lot of hands-on experience because that's important. I can reassure you that's not very costly because we can always bake our own little groins and do the job. But you need to have some investment in the mannequins and real-life equipment. But it's very much worth it because that's the only way to train up a whole team. Because it's a team approach, and particularly these patients normally end up in ITU. You want to have a cohort of ITU nurses that will be able to look after these people properly and get them out of trouble with the minimal amount of complications.
So as an intensive care physician then, should I be sending any patient with cardiogenic shock to a high volume centre to get an Impella in future?
The answer is depends where you work and depends on the experience of your interventional cardiologist. You don't want to delay the treatment of these patients too much because if you're in a place that your tertiary center is, 15 minutes down the road, by all means, contact them. We have this Teams meeting now, but, we're all over it. So, we tend to, at the Brompton and Harefield, we tend to organize shock calls with our peripheral hospitals when they are into trouble. And you'll be surprised how many times even just a piece of advice, it's calming, gives them direction, and also sets them the criteria they're looking for to refer to us. And we're very happy to get someone early on. If you think there's red flags that something is about to happen, we're also happy to come and retrieve if you think that patient's in deep trouble, SCI-D, for example, and there's no time. I think you have to, depending on your geography, use your local hospitals, use your retrieval services, and link up with those.
Fantastic. Well, fascinating results from a really, really impactful trial. So well done on getting those. Thank you for joining us again.
Pleasure.
The podcast. I know you've had a busy day. And thank you for listening at home. So as always, you can hear this podcast and all our other podcasts and conversations on our podcasting app, on topmedtalk.com, or on your podcasting platform of choice. Please do find us on your social media apps as well. That's Facebook, X or Twitter, LinkedIn, and also on YouTube. And keep joining in the conversations. Thank you very much.
Thank you.
Thank you.
Top Med Talk.
Thanks for downloading Top Med Talk. Don't forget to subscribe. Check us out on YouTube. And of course on social media. We're on Instagram, Facebook and X. Also, it's important to remember that Top Med Talk is the broadcasting arm of EBPOM, evidence-based perioperative medicine. We'd love you to find out more about that, and the way to do that is ebpom.org. Check out our website and find out about some of the incredible conferences we're going to be arranging across the year. ebpom.org.